And this is Dave, and I think I'm starting, and I'm hoping that either Kara or Kay is able to share the PowerPoint we sent at 1:51 this morning Eastern Time. Kay and Kara, has that one shown up on your radar screen yet?
I am checking my email. Best practice for our presenters is to share the slides on their own. But I can search
Okay,
for
let me see. Let me see if I can get started with that. Okay.
but I got them right now if you need me to share.
Well, calling the presentation up. Okay, got that. Now it's back to Zoom and share screen. One of the wonderful things about getting up at this hour is you have an excuse for almost all dysfunctions. There we go. Are you seeing my slideshow yet?
Yes, it's in the presenter view. If you want to put it in the slide view, you could, but we're seeing it.
Okay, and I'm thinking I put it in the slide view by getting it out of.
It's right at the top in between animations and review. There's slideshow
Yes.
and play from start all the way to the left.
Okay, slideshow.
Yep. And then scroll up a little bit.
Part of my problem is my Zoom command screen has decided to go up to the top and
Oh
mess
yeah,
with.
that bar.
So I'm trying to figure out how to make the Zoom screen go elsewhere.
You can usually drag it, but sometimes
It's,
stubborn.
sometimes if you try escape, it'll minimize it.
Okay, now I think I have it down. Slideshow. Yes, play from start.
And we're in business. Thank you.
Okay. And okay, and y'all told us that we had 15 to 20 minutes to do this talk. This will be fun. So, very good. So I'm Dave Cundiff, and we have a whole bunch of irons in the fire. I work primarily at a detox and residential rehab center a few miles away in Long Beach, Washington. And I'm an old public health physician, a past president of the American Association of Public Health Physicians, and also for the last 2 years, an elected member of the Council on Science and Public Health at the American Medical Association. The cool thing about what I do is I get to do so many different things. And for both of us, we have no financial disclosures. We will discuss off-label use of a medication in that the prescribing of buprenorphine above 24 milligrams per 24 hours sublingual is an off-label use according to the FDA, although we think the science is extremely sound. And we have to disclose that we might mention brand names in discussion because sometimes it's difficult to keep products straight without telling the brand names in addiction medicine. We have the usual acknowledgments, colleagues and patients. We all are standing on the shoulders of more people than we are ever able to acknowledge, and Dr. Grande and I are too. So our three objectives this morning describe physiology, pharmacology, and other research on the dose response effects of buprenorphine, examine the current regulations, other restrictions on bup use, and briefly introduce special situations like pregnancy and CYP induction. We started out with some assumptions about what good medicine involves, and I'm hoping that you recognize how we treat other illnesses such as diabetes, asthma. Good clinicians define the therapeutic targets, assess what medications and dose usually meets those targets, modify the dose for safety concerns, if any, modify dose for individual situations if needed. And the most important step of the whole cycle in medicine is monitor whether the therapeutic targets are met. And I'm hoping you all see the process that you go through with most diseases. And I want to talk you and use that as a framework about how we might think about buprenorphine dosing in the fentanyl era. So trying to get the, okay. Now, I'd like to start out by figuring out where you are with this and also with trying to come up with your ideas, because most of our time, the experience is we have all the knowledge in the group that we're talking with about what needs to be done for patients. So let me just ask you to start throwing in the chat, what situations or patient concerns in a few words would make you want to prescribe sublingual buprenorphine at doses greater than 24 milligrams per 24 hours? And if you like, you can unmute and just shout it out in this smaller group. But why would you want to prescribe buprenorphine above the state's limits? Dr. Block says inadequate control of withdrawal symptoms or cravings. Dr. Ballister, using fentanyl regularly. Dr. Block and Dr. Reyes, chronic pain.
Switching from methadone.
Wow, that's a good one. What else? Y'all didn't quite give our talk yet, but you're pretty close. You've got the most important: ongoing cravings, withdrawal persistence. Fentanyl is much different than heroin. Yeah. And it's our understanding that Ohio Medicaid still limits to 24 milligrams a day. Is that still correct?
My understanding that it is, but that there's some consideration for giving more autonomy to the prescribing physician. And if a person is addiction medicine certified, I think there is a loophole there that you can have some prescribing leeway.
Sounds good. When we started this work back in 22, when we started public presentations on buprenorphine doses, Oregon was still at 24 milligrams, and the Oregon Society of Addiction Medicine gives me way too much credit for Oregon's decision to raise the prior authorization requirements from doses above 24 to doses above 32. Let's see if we move on to the didactics again, and thank you all so much for that. Okay. So what's changed since 2010? I'm sure everyone who on this call has seen this graph in which the prevalence of death from synthetic opioids other than methadone, and mostly that's the fentanyls, has just taken off since about 2013. So much has changed epidemiologically since 2010. The high potency of fentanyl increases opioid tolerance, and the results without medications for opioid use disorder are just as poor as they've ever been. And I think that what the differences between states are primarily not the dose that's authorized, but it's primarily how many people actually have access to buprenorphine and don't. Dr. Grande's in a place where methadone programs are a few miles down the street. My place, 45 minutes in good weather, and in bad weather, sometimes you can't get to the methadone program at all, even with the best of vehicles. And high-dose methadone's got drawbacks, primarily drawbacks about the QT interval, but there are also some other issues with methadone that your methadone programs will know really well. Not everybody can get up to what's now a therapeutic dose. You want to blow people's minds. the buprenorphine dose you need to reach targets isn't the mind-blowing thing. What's mind-blowing is you're prescribing methadone at what levels? That seems to be the theme of methadone treatment in the West Coast and I think nationwide. So what hasn't changed since 2010? It's the FDA label on buprenorphine. And the politics of this seems to be that the label gets changed if the manufacturer makes a case. If the original manufacturer doesn't care to ask for a label changes basically don't happen other than with citizens' petitions, and that's pretty hard to get FDA's attention with that. So in 2002, they said maintenance dose usually 16, adjust to the level you need. This is likely to be in the range of 4 to 24 milligrams a day. And the majority of patients do well with 4 to 24 milligrams per day. Although in the fentanyl area, it's a bare majority. It's just barely over 50% in most of our practices. But the label's the same. Maintenance dose now is 4 to 24 milligrams a day. And they began saying doses higher than 24 milligrams a day have not been demonstrated to provide any clinical advantage. And in 2024, it's the same statement as 2010. The evidence base for that statement, there was basically no evidence for that statement when they began making it. And it has been more and more and more out of date. We were able to find from 2003 to 22, at least 16 peer-reviewed studies showing dose-dependent benefits up to 32 milligrams a day. Most of these are observational rather than randomized controlled studies, but we've got a little bit of various methodologies that show benefits within the studied range up to 32 milligrams a day, higher doses with greater benefit, and they are consistent. Going to talk about therapeutic targets from 3 different folks. One is from Dr. Mark Greenwald, who is, we are grateful, one of our collaborators on at least one paper, and Dr. Greenwald is probably the preeminent buprenorphine pharmacologist in North America. He's at Wayne State University in Detroit, right up the road from y'all. He says 3 therapeutic targets: no negative reinforcement, opioid withdrawal symptoms and cravings; no positive reinforcement, euphoria; no toxicity, which he would define as respiratory depression. Great, and actually a lot of that is measurable. The American Society of Addiction Medicine says, here are your treatment goals: suppress withdrawal, block the effects of illicit opioids so when people slip, they don't die, reduce opioid cravings, stop or reduce the use of illicit opioids, and promote and facilitate patient engagement in everything they need, including psychosocial work. Good luck measuring those treatment goals, but they make a lot of sense. Because I was always taught you need measurable goals, specific, measurable, actionable, time framed, and that T. One of them was relevant and then time framed. So I asked, is my patient meeting treatment targets? And here I got 5 fingers, and I used my 5 fingers to help me remember. Any psychological cravings for the drug, any time of day or night, because buprenorphine, when it is dosed and timed right, it eliminates the psychological cravings 24/7, including right before that next dose is due. And remember, I'm out where if buprenorphine fails, I can't just say, oh, well, they need methadone. If buprenorphine fails, I put them at risk of death if I don't treat them to the therapeutic targets. So the second therapeutic target, any withdrawal symptoms, any time of day or night. The third, any night sweats. Now, those of you who are physicians, remember this big, long differential for what's causing night sweats in my patient. And the most common cause once you get out in actual practice is, gee, I don't know what's causing those night sweats. But it turns out in addiction medicine, this is fairly easy because people with opioid use disorder, night sweats are withdrawal symptoms until you prove otherwise. Using dreams. Oh, I fought this. I said, dreams are psychological. There's no way that dreams are going to be influenced by the amount of drug on board. My mentors kindly said, try raising the buprenorphine and see what happens to the using dreams. And what I found is they consistently go away. So using dreams are now a sign of withdrawal. And finally, you get to the 5th therapeutic target, which is the objective in the first place, to suppress any use of any opioid that isn't prescribed for the patient and known to you as the buprenorphine prescriber. So I'm hoping that the therapeutic targets make some sense to you all. And then let's go into the physiology and pharmacology, and I will try not to put you to sleep with the difficulties of keeping track of all the arithmetic involved in dose response. I'll try to make this interesting. And if at any time you want a deeper dive, oh, bless you, we can try that. So plasma concentration increases with dose. And here is Greenwald's original dose response stuff in 2003. What we see is a peak of the buprenorphine serum levels in nanograms per milliliter. That's the vertical axis. A peak at about 1 hour, followed by rapid decline, followed by slower decline over time. And for those of us who are still prescribing buprenorphine once daily, which out here is pretty seldom, but for those who were, then what they get at the end is a serum level that is roughly 1/10 in nanograms per milliliter what the original dose was in milligrams. Now, with chronic doses, you'll get a little higher, but this is naive patients getting a one-time dose. You get this pattern, and you'll notice that the shape of the pattern is pretty much the same regardless of what the dose is, because the elimination half-life is 24 to 42 hours, with usually an average across the population of 33 hours elimination half-life. That means to get the full effect of any change in buprenorphine dose, that you need about a week. You get about half the effect in 2 days. And that's why it terrifies me to have patients reducing their dose within 7 days before discharge from residential care. They hit their worst time on the street. They sometimes leave us saying, "Still doing great." And we say, "Well, so is the guy falling past the 5th floor, but don't know what's going to happen once you hit that lowest serum level." So concentration is proportional to dose. Now, we asked, are there going to be safety problems with higher doses? And the answer is very rarely and virtually never are there safety problems with buprenorphine monotherapy. The only issue is when buprenorphine is combined with alcohol or combines with benzodiazepines or other sedatives, there's some unpredictable stuff. But buprenorphine toxicity for straight buprenorphine is absolutely predictable. The maximum respiratory depression, and these doses are 0.2 of a milligram intravenous for 70 kilogram person, or compared with 0.4. No change in the respiratory depression. This stuff is physiologically measurable, but it is clinically insignificant. And that's what we see out there in actual practice. There is no safety signal that limits the dose of buprenorphine. Now, is there a maximum for analgesia? There might be, but nobody that we know has found it and clearly demonstrated it. So it was really nice to hear you all say sometimes you need higher doses of buprenorphine for pain. Here is the maximum analgesia. It's a low dose study, but there's no maximum seen. And we're also going to present you a study from Deitch that doesn't show any maximum analgesic effect in a studied dose up to 32 milligrams a day. Many of you have seen this mu receptor occupancy. This is from Greenwald in 2003 again. These are 5 heroin-dependent volunteers. It's 2003. They've never seen fentanyl. And what we see is mu receptor occupancy that is low with low doses, fairly high with medium doses, and somewhat higher, significantly higher with 32 milligrams. Now, you will hear so many people say, well, the difference between 16 and 32 in receptor occupancy is clinically insignificant. And there's no empiric evidence for that statement. As far as I know, folks took Greenwald's stuff and extrapolated it to, well, patients seem to be doing all right, and so I'm going to declare 16 to be enough. That has about as much science behind it as the original letter to the New England Journal about opioid toxicity and the danger of addiction with opioids for pain. It was observational, it didn't look for trouble, and it wasn't randomized. And our clinical experience is completely refuting the idea that 16 milligrams is per se enough because the receptor occupancy in the 80s and 90s is enough. We don't know how much is enough for the individual patient. But in 2003, Dr. Greenwald was already saying high occupancy correlates with improved therapeutic effect, and the near maximal effect is 32 milligrams for this small number of people studied. 2014, things are getting a little more sophisticated. Blockade of subjective effects of high opioid doses may require greater than 90% occupancy, up to 32 milligrams a day. And Greenwald is saying as early as 2014, do not set fixed arbitrary limits on buprenorphine doses or on buprenorphine reimbursement. There's no reason for that. We're also different in so many ways, and what we need is different. So the suppression of opioid reward, it requires serum levels to be reliable of greater than 3.3 nanograms per milliliter, what we in our 2023 paper called you have to get out of the red zone. Oops, excuse me. You have to get this sensitive mouse pad here. You notice that below 3.3, the scatter plot still has quite a few folks up in the high range of the scatter plot. We haven't changed their drug liking scores very much at all. And the drug liking is measured with 18 milligrams of hydromorphone intramuscular. Notice the plasma concentration immediately below the graph, and then the equivalent sublingual dose right below that. So that to get people out of the red zone requires, depending on the individual, in the 24 to 32 milligram range, although some people, they get out of their personal red zone earlier. This is from the Sublocade package insert. Suppressing fentanyl-induced respiratory depression works best at 5 nanograms per milliliter, up at the upper end of that graph. You notice the ventilation effects of fentanyl are quite pronounced without any buprenorphine on board. We all know that. With a little bit of buprenorphine, you can smooth out the curve and have significant protection against death, but you still have an effect on ventilation. At 2 nanograms per milliliter, if corresponding roughly to 16 milligrams, you get better effect, and you barely see a respiratory depression at all once you get up to 5 nanograms per milliliter. Individuals with an injection history seem to need higher doses. Lafont put this together in the most formal way. Craving withdrawal abstinence reward blockade says, with injection history, you need more. Although how much of that is the history of injection and how much of that is the fentanyl history is another question. Special metabolic circumstances, and then you're done with me. Phenobarbital is increasingly coming to a withdrawal center, a detox center near you. It's increasingly used for benzo withdrawal, where it has few other things that will do what phenobarb does. It is increasingly used for alcohol withdrawal because it's less euphorogenic than a lot of the benzodiazepine options. But for patients with opioid use disorder and patients on buprenorphine, you must know that phenobarb is a powerful CYP3A4 inducer. The onset of induction of 3A4 induction is delayed by a few days, so you don't always correctly attribute it to where it started, and the resolution of that can take weeks. It dramatically reduces buprenorphine blood levels while the induction lasts, and to counteract it, the tools that I know you got is grapefruit. Although remember that 3A4 affects half the pharmacy, so get a clinical pharmacist involved unless you are incredibly good at analyzing 3A4 interactions, and go up to the bute dose you need. The only patients I've had to put on buprenorphine 48 milligrams a day to meet therapeutic targets, one of them was phenobarbital patient, and a couple of them were patients in the 3rd trimester of pregnancy. And that's going to be Dr. Grande's work. So what happens if our systems don't change? Well, prior authorizations will continue to incentivize subtherapeutic doses, and that will kill some people who are even in treatment by facilitating relapses that didn't have to happen. The pharmacy limits and the stigma will continue. Oh, you need that much. You must be abusing it. Transferring care gets difficult when we're not on the same page, and those transfers of care can mess with transfers from one clinician to another in similar settings, but also transferring from residential to outpatient. When we have patients who need high-dose buprenorphine to meet therapeutic targets, we're scared sometimes. And there are cities where we are still maintaining patients long distance on the doses that we know they need, and they know they need, because they can't find prescribers at the levels that they need in their cities. People are hung up on dose limits and not on therapeutic targets. I get hung up on therapeutic targets. And community to jail, don't even get me started. There are lots of variations across the country and across our state in what the jails will do for people with opioid disorder to keep them comfortable and to keep them moving ahead so that they can, their time in a correctional setting is well spent from a substance use point of view. They still need medications for OUD when they get out, but it's just cruel to withhold the medications while they're in. So now we're going to Dr. Grande's more clinical research, but there's your overview of the pharmacology involved. And if we have time for the discussion, that's going to be great. So Dr. Grande, tell me when to change your slides.
Yes. Okay, I'm going to be switching over.
And
Do you
thank
You want to
you,
present your own?
Okay, where is
I
my,
can run my stop share.
hold on a second. That's not the right one. There we go. Slideshow. Current slide.
And has
Okay,
it gotten rid
hopefully
of?
you guys can all see that.
Yes,
So
get rid
thank
of
you
my
very much.
slideshow.
What, can you see that?
I'm thinking that's entirely your slide and my slide's gone. Are you
Yep.
seeing? Okay.
All right, thank you very much. I'm going to go really quickly because I know we don't have an awful lot more time, but thank you, Dave. And just so you guys know, Dave has a lot of expertise in this area, but he's got about 15 other areas that he also has an equal amount of expertise from many years of research and work in public health. So I'm going to just talk quickly about the clinical research that's been done that demonstrates the benefits, the dose, the benefits of dosing at 32 milligrams or higher. This one is one of my favorite studies because the graph is so clear. It shows percent of completion of a 24-week program with both as a function of dose of both methadone and buprenorphine. And in this graph, the methadone rates are above and the buprenorphine rates are below. If you imagine dosing at a slightly higher rate, then you could shift that curve up and buprenorphine would work as well as methadone. But as you can see that the completion rate, people who made it all the way through the study period continued to increase. The ratio of people, the proportion of people who completed increased as the dose went up, and it looks like it continues to go up beyond perhaps 32 milligrams, so that if people had been at a higher dose, you might have had even more people complete. So 32 milligrams per day or even higher may be needed for optimal benefit for some of the patients. So here is a study that looked at reduction in illicit drug use. It was a meta-analysis that included 2,703 patients. And they divided people into low dose and high dose groups for summarizing all these different studies together, and found that the high dose group, which was 16 to 32 milligrams per day, had better retention in treatment than the low dose group. And they also found that there were fewer urine tests positive for opioids and cocaine. They also, there's 2 studies at least that showed better adherence to the prescribed drug. And this one was a study of prescription drug monitoring program data, and they were able to look at a much larger number of patients. And the way they categorized adherence, I think, is a really practical way to think about it. the number of the percent of days covered. In other words, if you write a prescription for a month, how many days was the person actually using it? And it really works best over a period of, say, 6 months. And over the period of 6 months, did they receive 6 months worth of prescriptions or only 3 months worth of prescriptions? Then that would be 3 months worth would be a 50% adherence rate. And they found that the adherence after 180 days at the highest dose, 24 milligrams and above, they had 50%, 53% adherence, and it decreased along with the dose, so that the people that were at the really lower doses were much less likely to have a full adherence over the course of the time. So 6 months adherence. Using patient, I can't even read the wording here at the top, but perception as the measure of dose adequacy. When we take care of patients, we, like Dave was saying early on, that we use whether the patient reaches their treatment goal. And if the patient is staying on their treatment, then that's one of the measures that we use to determine if they're reaching their treatment goal. And if they perceive it as being adequate, then that's what's gonna cause them to continue using the treatment. In this study of 48 patients, they were allowed to increase their dose to reach a therapeutic target according to their own perception, and they could increase their buprenorphine dose up to 32 milligrams a day. And at that point, if they were still not finding relief of their symptoms, then they would switch over to methadone. And this is a population of people who had a lot of experience with opioids, average heroin use of 9 years. And of all the people in that study, 17 of them were satisfied by the buprenorphine dose that they had settled on. And of that group, 29 milligrams was the average amount of buprenorphine that they were using. And then the ones that switched to methadone were not satisfied by a dose up to 32 milligrams. And they found that the people that were using buprenorphine and the ones that ended up switching to methadone had an equal retention rate and results on urine test results. So as was mentioned by the people in the chat, chronic pain is one of the things that actually does seem to respond to buprenorphine. And this is a little known fact that I guess some of you guys already appreciate, but it's widely not yet appreciated. There's very little research, in fact, none that I've been able to see, except for this one guy, Jonathan Deitch, who did 2 studies, one in 2014, and they're observational studies, but one of them was, he's got a pain clinic in Florida, and he transitions patients who are on high-dose opioids who are not thriving on the high-dose opioids, switches them over to buprenorphine. And in this study, he looked at patients who had been on 200 milligrams of opioids and found that when they transitioned to buprenorphine, their average buprenorphine dose was 28 milligrams per day. And at that level, their average pain score dropped from the 7.2 on average down to 3.5. So this treatment was incredibly helpful for those people. Most of my experience comes from my work at the Olympia Bupe Clinic, where I was co-founder and medical director for about 3 years at this low threshold clinic, where we treated a lot of people who were injection drug users and had a lot of a long history of opioid tolerance. And in this analysis of prescription monitoring program data, I looked at 242 patients, and our standard of treatment was dosing to clinical effect. We tried to make the patients comfortable. And in order to show what our dosing range was, I looked at prescription monitoring program data for the Washington State as a whole, and then our clinic. And as you can see, the average, the highest number of people were in the range of greater than 16 to 24 milligrams, and we had a significant number of people at 32 milligrams or more, and mostly not too many more than that. 32 milligrams was usually the highest range. And that was what worked, and we were able to do that because Washington State Medicaid early on allowed dosing up to 32 milligrams. And so that was the flexibility that we had that allowed us to do this analysis. And the most important results, I think, of this were looking at correlations between patient characteristics and the dose that they settled on. And chronic pain, there was a strong correlation between the likelihood of being on the greater than 24 milligrams with people that had chronic pain at the time that they came in to the clinic. This was patient survey characteristics at the time that they first came into clinic. PTSD and measures of long-term use, which were patients saying that they had duration of use of more than 10 years or that they started at less than age 18. Those were characteristics that people seem to be more comfortable on the 32 milligrams. So just quickly, buprenorphine dosing in pregnancy. Higher doses are needed in pregnancy, and there's multiple reasons for this, but the increased volume of distribution during pregnancy and the increased clearance as a result of how the body processes the various drugs results in serum concentration of buprenorphine 50% lower during the 3rd trimester of pregnancy. So you can imagine that the same dose, if you maintain the same dose throughout pregnancy, then you'd probably have people a lot less comfortable, more withdrawal symptoms and craving. And the way that is, they also found that the way that's managed, that if you dose people more than once a day, then they're going to maintain a better serum level. And this shows, this was a study using the physiologic baseline. They measured them after delivery, and you can see that the peak level, they only compared 4, 8, and 12 milligrams in this particular study, but the peak level was much lower. It went on the graph on the right. You can see it went up to about 5 nanograms per milliliter at the very brief period of time right after dosing. Well, the baseline before pregnancy and after delivery went up to 7 and stayed there longer. And as a result, dosing more frequently, you would have the patient spend more time at that higher dose range. And this is important. There's a number of studies now that have shown this, that there's no relationship between the patient's dose and the risk of neonatal opioid withdrawal symptoms, also known as neonatal abstinence syndrome. And it's kind of counterintuitive, but if you think about the processing that goes on in the placenta, the placenta is very individual in how much buprenorphine ends up getting screened out or getting excreted, and the fetus is not maintaining the same serum level as the mother. So really, you need to take care of the mother as best to keep her comfortable, and the baby will do well. There will be some withdrawal symptoms, but it's not related to what the dose was. And that it's counterintuitive, but here's 3 studies that demonstrate that. And of course, we know that a happy mother is going to make a happy baby. And there's also another factor that's come into play in recent years, and that is eat, sleep, and console as a strategy of taking care of newborns. And that greatly reduces neonatal opioid withdrawal symptoms. So briefly, in conclusion, buprenorphine dose is adequate if the patient perceives it as adequate, if there is less use of illicit opioids, and if the patient is retained in treatment. Those are measures of success. That there's preclinical and clinical evidence that 32 milligrams a day or higher is helpful for some patients, particularly those with injection drug history or chronic pain. And pregnant people need an increased dose of buprenorphine and do best with an increased frequency of dosing known as split dosing. So I'm going to stop sharing, and hopefully we have a little bit of time for comments and questions.